All right. So, hello everybody. Um, just kind of going off of some things, right? We're kind of going to approach these new meds now, upcoming from week three to till we finish, right? For pharmacology. So the biggest thing that I noticed when I was doing my readings beforehand, when we started the semester, is that we have the our first 8 week. Our first 8 weeks worth of meds are really heavily based on our neurotransmitters. So I decided to make this little presentation just to kind of give you guys an idea of like why it's so important to kind of understand these the mechanism of action of these neurotransmitters, because knowing that will help us kind of understand the side effects, which will eventually also help us understand like the education that could come with it too. So I decided to pull the biggest neurotransmitters that I've noticed, and then I'm just going to present them, kind of talk about them a little bit. I'm going to talk about the neurotransmitter and the specific receptors that they go to, and then what like the effects that happen because of the receptor being either agonized, meaning like it's encouraged, or antagonized, meaning it's blocked. So just a quick intro. The slides are more meant to help understand the side effects and adverse effects of a lot of these medications. Maybe if you guys have done a little bit of your own reading or even seen a little bit of these medications, a lot of these medications, especially the psych ones, they all kind of have the same side effects. So with that, again, it'll help out. It's for the first 8 weeks, as we mentioned before, right? There's a lot of relation to this. Keep in mind it's a work in progress, right? There chances are there could be some information that might not be the most accurate here, but this is how I've been taking it away, and it's been very helpful with me. So as always, if something's wrong, do let me know because I got to correct that so we could all get the right info and move on from there. So so the big ones, right? So right here, I'm going to go over 6 different neurotransmitters in this video, right? Over there on our left, we have the acetylcholine. A lot of it is related to like muscle movement, learning, memory, attention. But the biggest things that I want you guys to kind of really take away is if you could look at the bottom right there, there's going to be down here this acronym called sludge. That's going to be really important to know for later because there's going to be a lot of you guys might hear a medication that is a cholinergic or an anticholinergic, and just with understanding sludge, for instance, it will kind of help you understand, oh, that's what the side effects are going to be in relation to that, right? So again, it mainly helps with a lot of like muscle contractions. If anything, like I guess a fun fact, acetylcholine is kind of like the standard, most generic neurotransmitter that's just used in order to get messages from across the pond in the synapse of our body, or our central nervous system. So that'll kind of help out. But a lot of it also, there's regulation of parasympathetic functions, and that's what's related to sludge. Because what is parasympathetic? What's the first thing that should come to mind is rest and digest. GABA, right? GABA is pretty cool because it works as a natural inhibitory neurotransmitter. So it's a little different compared to these other ones because usually high levels of something will increase some kind of production or some kind of activity. But in this case, GABA, since it's mainly an inhibitory neurotransmitter, it has a lot to do with just calming the body down. So we'll go into like certain medications that go with it. And usually, it calms all neuronal activity, it reduces anxiety, it prevents overexcitation, and it can even prevent seizures, right? A seizure is at the most primitive form, overstimulation of the central nervous system to the point where our body shorts out and we have convulsions with it. So as always, these are just kind of like repeats. It's all about calming down the body. Dopamine, right? A lot of it has to do with reward. We hear about like, oh, a quick dopamine fix or whatever, right? um, it also has a lot to do with motivation because we look for, that motivation gets us to that reward. Has a lot to do with movement too, so that will be very heavy in relation to Parkinson's disease, and then attention as well, and that will also be very big in terms of schizophrenia. So big takeaway: high levels of dopamine will lead to schizophrenia, low levels will lead to Parkinson's disease, right? So I guess right now, let's the big thing we'll look at dopamine. Dopamine has a lot to do with attention, it has a lot to do with like motivation and stuff, right? Imagine if our body was very, very, what's the best way to put it? Like, imagine like we have way too much attention, right? You might possibly even interpret things that might not be occurring because you're overly kind of like you're trying to intensify, your body's intensifying the action, and it's making you kind of think something's occurring that isn't really there, whether it's an auditory hallucination or a visual hallucination. That's kind of where the whole schizophrenia could come in. Obviously it's not fixed, but that's what science is kind of saying right now. So that will kind of help you understand in terms of schizophrenia, and why certain side effects occur when you take antipsychotics that treat schizophrenia. Why is it that some people get these Parkinson's like symptoms? And we'll go into that in a little bit. Finally, one of the most slightly complicated neurotransmitters, but not too terrible, are serotonin. Its chemical structure is 5-HT. I really don't know what that stands for, but I just know that 5-HT means serotonin. So just kind of like an FYI, sometimes some things have come up where it's asked like, what is a 5-HT? Big thing to do with it has a lot to do with mood regulation, sleep regulation, appetite, and emotional regulation. So a lot of regulation towards general body functions. And funny enough, that's where our SSRIs target. Also our SNRIs, a lot of different other medications that are specifically tailored towards depression. Um, Typically, what it does, it stabilizes your mood, it regulates your sleep and appetite, right? Sometimes it triggers being hungry, other times it suppresses. It just depends which receptor is being triggered. And then obviously, it can influence anxiety and emotional processing. And finally, the last two, and I paired them right next to each other, is because you typically have one and the other. Um, Fun fact, I guess, norepinephrine is a neurotransmitter. Epinephrine is a hormone. So typically, norepinephrine kind of modulates the release of epinephrine. They're both released from our adrenal glands in the medulla part of the body. I mean, that's more just fun fact kind of stuff. But long story short, norepinephrine is the signals that help release more epinephrine, but norepinephrine, I'm sorry, happens to have its own functions too. A lot of it has to do with alertness, attention, its stress response. A lot of times, right, epinephrine, we hear like, adrenaline, right? So usually when we hear adrenaline, we want to think a sympathetic nervous system response because our body is very like wired and our attention is high, we're in fight or flight. So a lot of it has to do with increasing alertness and focus for norepinephrine, right? There's fight or flight, as we mentioned before, and it regulates blood pressure and heart rate, typically uh, punching up the heart rate and the blood pressure at the same time, right? Epinephrine, same effect. It's the stress and emergency response hormone, right? And right there's that reminder that it's more of a hormone. It increases heart rate, boosts energy, and it enhances rapid responses to danger. All right, so now that we got that out of the way, we could get into the actual neurotransmitters and what they do, right? A lot of this stuff might sound a little boring, but again, it's very helpful. It's helped me understand better, and it kind of gets me more into the like understanding side effects. So we'll go into acetylcholine, right? So acetylcholine typically has two receptors that they target. They can target nicotinic receptors, and fun fact, that's actually one of the receptors that when you smoke nicotine makes its way to the nicotinic receptors. And it's just fun fact, like that's actually why it's called nicotinic. It has a lot to do with fast signaling, muscle contractions, and autonomic nervous system function. Typically, the medications we're looking for, we're not really going to be paying too much attention to nicotinic receptors, but just be aware that ACH happens to touch on that one. The biggest one we should really care about is this muscarinic receptors, right? This here in blue. These are slow signaling. It's all about memory. It's a lot of, in terms of regulation of like heart rate and digestion. These are the ones that we're going to be talking about in relation to that acronym below here that's called sludge. And again, we'll go into it a little bit more, right? So just I guess as a quick teaser, muscarinic receptor, function has a lot to do with digestion, right? We talked about rest and digest. So when we have rest and digest, we're able to digest our food, obviously. We can make secretions, we can pee, we can relax. Like our whole body's relaxed. We don't need to reserve any fluid. Our pupils in our eyes constrict because we don't need to take a lot of information. Our lungs, our bronchioles, and our like our respiratory tract constricts because there's no need to take in so much air. So a lot of that, if you agonize, right, meaning encourage, enhance, or whatever, the action of, like for instance, this muscarinic receptor, you get wet, slow, and constricted kind of functions, right? We talked about wet as in like producing secretions, slow because we're in rest and digest, constricted because again, our our respiratory tract becomes constricted. That's what it's talking about. Another way to remember is soaked, slow, and squinting, right? Because again, we talked about like in our pupils usually constrict when we're relaxed, right? It's like a person who has undergone a opioid overdose, right? They're very relaxed, so their eyes are very pinpoint. As for antagonist, oh, and I'm sorry, one way to recall this is cholinergic activity. An agonist for these muscarinic receptors, this is cholinergic activity. So whenever you hear cholinergic, I want you to think of this, the wet, slow, constricted. Remember, wet meaning like we actually produce secretions in our mouth. We can digest, slow in terms of rest and digest, constricted because our respiratory tract doesn't need to be too dilated because we're relaxed. So same, repeat for that one. Slow, same thing. And then squinting because our pupils are constricted. And then for this antagonist activity, I want you to think of anticholinergic, right? And what we just said is, right, we said this is cholinergic, so, and we just went over this. So the anti is obviously just the opposite. Now everything's dry, everything's fast, everything's dilated, and you could even be confused, and then there's a very fun like kind of saying that a lot of people use when it comes to anticholinergic activity. It's can't see, can't pee, can't spit, and can't shit, because a lot of times this is a type of activity that sort of mimics a sympathetic nervous system response. It's not one to one, but it has a lot of similar effects, right? Dry in the way that we're not going to be digesting. Our body's going to retain fluid because we're not going to pee, because that means we're losing fluid, and our body doesn't know when's the next time we're going to drink water. So we need to reserve that. Fast in the way that we need to move fast in if we were to be in a very dangerous situation, right? Everything needs to move quickly because we have to move quickly. Dilated, both talking about the respiratory tract and our pupils. Respiratory tract because it allows to bring more air to perfuse us, and then our pupils because it lets us take in more information when we go about and run away from danger. And then confused, I guess, a way to use that to remember is just like, right, like imagine you were in a car crash and you weren't paying fully attention, and now you just have this surge of adrenaline. And I know we talked about adrenaline as one thing, but this is what I'm talking about: sympathetic nervous system response, right? Fight or flight. We're going to be confused. So again, anticholinergic, I want you to kind of take that as a sympathomimetic activity, because of its similar side effects in the way of like being in fight or flight. So now moving on. This is just something to go over briefly because again, we don't really touch on nicotinic receptors that much when it comes to acetylcholine. But if agonized nicotinic receptors, they can cause muscle twitching, right? Muscle weakness as well. So it's all about modulation. It can do both. And then we talked about earlier, it has a lot to do with the autonomic nervous system function. There's initial stimulation of both the sympathetic and parasympathetic. Again, we don't need to go that crazy into it because we don't really touch on this with medications. And then if antagonized, right, we're doing now the opposite. At the neuromuscular junction, it can cause muscle weakness, flaccid paralysis, A lot of paralysis related stuff. This is kind of more just like there's twitching, there's movement going on. If it's agonized, if antagonized, it's a little bit more paralysis because the message isn't being sent across to, hey, let's actually, contract. Um, and then, if you're not sending messages to contract, it could also, like lead to loss of autonomic tone, meaning vasodilation, like a lower BP and a variable heart rate, depending on if the heart is affected that way. Now, this one is the most important. This is the one that I really want you guys to pay attention because it really has helped me to understand all these effects that have gone on with anticholinergic effects, anticholinergic medications, because it really helps out. So, anticholinergic is here in red, but we'll touch on cholinergic first, right? Because if we learn this, then anti is obviously just blocking whatever's going on up here. So first of all, we'll go through sludge, right? Salivation, lacrimation, urination, defecation, GI motility, and emesis, right? So vomiting at the end. So cholinergic is everything that is sludge, right? And I guess as a bonus, I added a couple extra effects that happen in cholinergic effects. Pinpoint pupils, right? We talked about how, again, cholinergic has a lot to do with rest and digest. There's those pinpoint pupils. And then I added meiosis because they would throw a term like that at us to remember or to be tested on. So careful with that one. Bronchoconstriction, as mentioned before, bradycardia, because again, everything's low, we're low and slow, and then sweating and salivation. So again, that's like this right here has all to do with cholinergic effects. Over here at the bottom, this is anticholinergic effects, right? That's where we're going to have basically no salivation, no lacrimation, no urination, it's just no of everything we just went to, and also the opposite of whatever's going on, right? So if in anticholinergics, there's going to be dilated pupils, which is my dryasis, or how I can't really say it fully, but that's where the dilated pupils comes in. And then if your pupils are too dilated, right? Imagine you just walked out from a dark room into the sun. It's pretty bright, so you get blinded. There's that bronchodilation, right? Because a lot of anticholinergic medications for the respiratory tract cause bronchodilation. So there's kind of like a quick reminder from first semester. Tachycardia is a very common side effect of anticholinergic effects. Hyperthermia could also occur, mainly because there's no sweating, right? We can't sweat, so sweat is a normal way to help us regulate our temperature, so we don't sweat. We could easily get overheated. And then finally, at the end, confusion, agitation, and hallucinations could occur in the elderly. So I guess a way to kind of remember that this could happen over here at the bottom, the confusion, agitation, and hallucinations. Unfortunately, a lot of people use Benadryl, which happens to have a lot of anticholinergic effects, and they use that as a recreational drug. And one thing that I've understood is that when you take way too much Benadryl, you could actually start having hallucinations associated with it. So that's kind of one way that I remember especially for the elderly, right? They sometimes overtake medication, they take way too much, and they're very frail, so they're very at risk for these types of symptoms at the bottom. So big, giant takeaway. My biggest advice is learning this will make a lot of the medications that we learn a little bit easier because sometimes, it's so many different side effects. As for GABA, right? Now, GABA, and I made sure to highlight it a lot in yellow to kind of note the pattern here, and I made sure to make this font way bigger than everything else, is that it has everything to do with inhibition, right? It's an inhibitory neurotransmitter. That means that's all it does. And where it gets to, it has everything to do with inhibiting the central nervous system. The two receptors that we really need to pay attention to is not this one in orange, but this one in pink and this one in blue, GABA A and GABA B. Luckily, GABA B only really has one medication that really is targeting that receptor, and GABA A has a flurry of different medications that target that receptor. So I guess to go briefly, for GABA B, we'll think of like GABA back, right? Because we have baclofen. right? Baclofen is given a lot of times for muscle rigidity, spasms, things like that. So, for instance, baclofen attaches to GABA B receptors to create that effect of muscle relaxation, right? So, or that anti-spastic effect. So, kind of cool, very simple mechanism of action, and learning it that way helps kind of know the other effects that occur later, or like the side effects, right? GABA A has everything to do with like anxiousness and things to do with that, right? That's where we get medications like benzodiazepines, we get barbiturates, we get zolpidem, we get propofol. All right, we're good. So now going back to GABA A, right? It has a lot. Several different medications that target GABA A receptors. A lot of benzodiazepines, a lot of barbiturates, zolpidem, propofol. These all target GABA B. So they specifically go and increase the effect of inhibition. And all these medications are already the ones that we're going to be learning, or we've already learned about, for anxiety and insomnia. So again, we'll now just go over what happens. So the key idea again, focus on GABA A, GABA B. GABA A, everything to do with anxiety, right? GABA A, anxiety. GABA B, we'll say back because of back pain, back spasms, and all that kind of stuff. So if agonized, GABA A receptors can cause sedation. They can cause anxiolysis, meaning just breaking down anxiety, meaning you're getting rid of anxiety. Anticonvulsant effects. They can also be used for seizures. Ataxia, right? Impaired coordination, just because imagine again, like your central nervous system is basically being inhibited. So that's where that's coming. Slurred speech, again, you're under the influence of these types of medications. Memory impairment, because again, your central nervous system isn't functioning at its highest level because it's being inhibited. Respiratory depression or coma, especially at high doses or IV routes. Um, if antagonized, right, we talked about all this agonized activity for GABA A is causes inhibition in the central nervous system. So that means the opposite occurs if we antagonize these receptors. Anxiety, agitation, insomnia, seizures, tachycardia, delirium, hallucinations. Again, so it's just like mirror opposites, right? Black and white. And then very simply, GABA B, if you agonize or enhance the effect of those receptors, it causes more muscle relaxation, ataxia, which we went over earlier, just because, it's relaxing the body. And then if antagonized, it could lead to tremors, rigidity, and hyperreflexia, which is kind of all in the same realm of the same side effects that can occur if you antagonize these receptors. Now we're moving on to dopamine. Dopamine mainly goes into two different types of categories of receptors. The biggest ones that I think that we're probably going to need to pay more attention to is this inhibitory receptor, and it's D2. There's a lot of receptors that dopamine touches on, but I generally think that we're only really going to be focusing on D2 receptors because a lot of antipsychotic medications are D2 antagonists. So it just goes to show, a lot of these neurotransmitters, they can kind of go into different areas, whether it's excitation or inhibition. But again, I guess for our sake and to keep things brief, it just has a lot to do with, we'll just touch on D2 more than anything, right? So, um, you know, if agonized, right, dopamine receptors can cause a flurry of different things because, again, it depends which receptor is being touched on. But if there's, for instance, a lot of dopamine in the system, it can cause psychosis, so hallucinations and delusions, the mania behind it, insomnia, right? A lot of just overstimulation, but also it can cause improved Parkinson's symptoms. But it could also cause dyskinesia just for the sake of restless movement. Not that there's difficulty moving, it's just there's too much movement, like the feeling of you want to move a lot. It could also cause nausea, vomiting, and orthostatic hypotension. So again, it just depends what receptors, but typically this is what happens when dopamine receptors are agonized. I couldn't get too into the specifics because we'd have to break down every receptor. So this is just more a general look at it. Um, Here at the bottom for antagonizing those receptors, right? And I highlighted them because those are the biggest effects in relation to D2 receptors. You get less hallucinations and delusions, but you could also get Parkinson's like symptoms because now you're bringing down the availability or the function of dopamine. Um, and then that's where we could get like tardive dyskinesia. There has been some medications before that we have talked about that can do an antiemetic effect as well. That's like promethazine or chloromazine or something like that. But promethazine, I know that one is an antiemetic drug. So that's just kind of more of an FYI. And then the big thing to watch out for too, there is neuroleptic malignant syndrome. That is where a person has like a pretty bad adverse effect in relation to the use of antipsychotic medications that can lead to like a fever, rigidity, autonomic instability, and a high CK, meaning there's some kind of organ damage occurring. So just again, this is a brief overview of what's going on. Big things to watch out for is these yellow highlights, and then this acute dystonia and tardive dyskinesia. Those are the big ones we want to watch out for these antipsychotics. And then I guess there's like kind of an additional fun fact because D2 receptors normally lower prolactin levels, prolactin hormone levels, which help make milk, for instance, in women. Um, if those receptors are agonized, right, you're just increasing the inhibition of prolactin, right? But and so it can, improve the effect that there's too much milk production, and then infertility, it can actually improve the infertility. So now you can become fertile, and you don't make as much milk anymore because you're now because usually breast milk development it still holds off the ability to be fertile. Um, but now, one of the biggest side effects that occur when it comes to antipsychotic medications are these very odd side effects, like for in men, gynecomastia, there's sexual dysfunction, and even like no rhythm in the menstrual cycle or like even milk production. So, right, if the D2 receptors are antagonized, which usually happens in antipsychotic medications, prolactin levels are held back by D2 receptors, but if you block them, they're now allowing more prolactin levels to go up. This is why these side effects occur often, and then that's why maybe you'll wonder, oh, why is it that a male patient could possibly develop breasts using antipsychotic medications? This is typically why it occurs. Now, here comes the most complicated of all of them in a way, just because of understanding the highlighted ones or the one like in gray or color are the most important ones to really watch out for. But again, this is just a general brief overview. It is there's way too many receptors. There's a lot of them, but I mainly would advise to just watch out for H5T, right? Serotonin, that's one, and then there's A, and there's so many different others, but mainly just H5T1, H5T2, and then there's A and C. This is kind of where we're going to get like, the contrasts of each other. I guess as a fun fact, a medication like ondansetron is a 5-HT3 receptor antagonist, which leads to that antiemetic effect. So I guess fun fact. But well, let's get back to these psych meds, right? So a lot of them have to do with SSRIs, right, to improve the depression and mood. Um, so I guess the biggest thing, look up here, right? Agonist, right? Enhancing too much serotonin. You could be jittery, nauseous, flushed, and sweaty. But antagonists, like right, like in for instance in depression, there's too little serotonin, or it's being blocked. It could cause sleepy, constipation, hungry, kind of calm. Again, that's not always the case, but there's it's just kind of these are little things to kind of help you understand in a way, right? So let me get more into the kind of the nitty gritty, but That's why it's a little tough to really decipher everything because, like 5-HT1, right, if you agonize it, it can improve depression symptoms. But 5-HT2A, if you agonize it, it can make depression worse, which is weird. And then C, 52C, or 5-HT2C, the blue, to make it easier, and like it's really weird. It has everything to do with appetite suppression if you agonize it, or increased appetite if you antagonize it. It's very all over the place. So let's not overcomplicate things. Let's just be general, right? So generally, if serotonin receptors, like for instance, when we have SSRIs, we're preventing the reuptake of serotonin, allowing more serotonin to be in the synapse. That allows more serotonin receptors to be agonized. It could lead to a calmer mood, right? Sleep improvement, but it could also cause insomnia in some cases because there's always a possibility of a paradoxical effect. Anxiety can be reduced. Appetite suppression could occur, but also appetite could be improved to the point where you gain weight, which typically weight gain happens a lot more than weight loss, but appetite suppression could be possible depending on which receptor. But I guess to be general with SSRIs, weight gain is usually what happens. And then increased gut motility, right? Like a lot of movement, it could cause cramps, but again, depends what receptor. And then for antagonized action towards the receptors, it could lead to sedation. It could lead to an increased appetite, again, depending which receptor. And it could slow gut motility because again, it's blocking it away, right? And then prevention of nausea vomiting, but that's talking about Zofran. So mainly let's kind of focus on this one. And then this does have a caveat in the appetite suppression section. Let's think more weight gain because that's just an unfortunate side effect that occurs with SSRIs more than anything. And SNRIs and TCAs, usually it's weight gain more often than not. But I put that there just because, again, it's very tough to follow the trail because there's so much information. We can only do so much. Finally, we're now coming up on our last two neurotransmitters, and luckily both work off of each other. Norepinephrine, I highlighted the receptors that they mainly touch on. They'll touch alpha 1. The duty of alpha 1 is everything to do, it has one job. Alpha 1 has one job, and it's vasoconstriction, right? Alpha 2 is a little interesting because it has a lot more to do with a negative feedback loop in relation to changing global. It's more in charge of central nervous system relaxation. It works as a negative feedback loop in the way if there's too much norepinephrine, there's no need to always be wired and in sympathetic nervous system response. So we will always, have a way to keep us in check. That's what the alpha 2 receptors are for, because they lower the release of norepinephrine and by proxy epinephrine. And then they also help lower heart rate and lower blood pressure. The thing is that it's like which signal is being kind of taken, right? It's always like a homeostatic kind of like trying to balance everything out. And usually sometimes the signal is more stronger towards alpha 1 and beta 1 than it is to alpha 2, but sometimes it could be alpha 2 that takes over. It's just, again, that's why. So to be brief about it, alpha 2, two jobs: lower the heart rate and lower the blood pressure via vasodilation. Beta 1, right? We talked about our beta blockers and mainly target beta 1. They have one heart. There's beta 2, two lungs, but we're not going to talk about that one with norepinephrine because it doesn't really have an effect on it. But it does have an effect on beta 1. And it has everything to do with contraction, like force, like the force of the heart, and then also like the heart rate, like spiking or going low, right? But with norepinephrine, it typically makes it pump harder and faster. So again, these are the main highlighted ones that they target. But obviously, alpha 1 and beta 1 are the ones that are more sympathetic nervous system response. Alpha 2 tries to keep, alpha 2 is like the adult in the room that tries to keep everything under control. Obviously, sometimes that doesn't always happen. Alpha 1 receptors, if they're agonized, right? We talked about alpha 1, one job. They cause vasoconstriction. They can cause dilated pupils, right? Again, a lot of sympathetic nervous system symptoms, right? Urinary retention, same effect. Piloerection just means that your hairs stand. Um, Pale, cool skin, which is kind of interesting. It could be just because of the extreme vasoconstriction. However, sometimes that could also show up as a person in shock when their blood pressure is too low. So, yeah, again, it depends. And then headache too, because of vasoconstriction. Too much pressure going to the head, it can kind of cause a headache. I guess like in a fun fact, a lot of the drugs that are for men with enlarged prostates are alpha 1 receptor blockers. So, like for instance, one of the most common medications for it is prazosin. That is a medication typically that can be used for both hypertension, but mainly it's used for um, the enlarged prostate. And then if you block the alpha 1 receptors, obviously it's going to be the opposite of everything we just talked about when it comes to agonist effects, right? So it's going to cause vasodilation. So warning, hypotension, orthostatic hypotension, a relaxed bladder and prostate, right? Allowing for the urination. It could cause dizziness, syncope, reflex tachycardia because the heart typically, is gonna all the vessels dilate, but the heart's gonna compensate in some way. That's typically with reflex tachycardia, and it could cause nasal congestion. So same thing, same effect. Alpha one blockers could target the nose to prevent like allergic rhinitis too, like symptoms like that, because blood vessels are the highways of the body. They carry blood. They have fluid. If those vessels are dilated, the fluid can kind of transfer out as well. But that's kind of where it goes into. So alpha one, right? If you agonize it, a lot of sympathetic nervous response. If you block it, a lot of parasympathetic style or type of responses. So again, being able to kind of get this down and understand. I may be going quick, but if you kind of stop, you take a look at it, and you kind of notice that black, white, you'll be able to catch on and kind of helps out with all the drugs that we go over. Alpha 2 receptors, right? If we agonize it, it's like I talked about, it lowers norepinephrine release. So it helps calm the body down. So it could be confusing. It could be very difficult to, kind of be able to catch all that information. But again, taking a look at it, kind of getting to understand it, it really helps out. But there's that sedation, the bradycardia, hypotension because of vasodilation. Funny enough, it causes dry mouth, which you would think it wouldn't because it's relaxing the body to be in rest and digest. That's why I italicized. It's a bit of a unique thing, but that's what came up when I researched it. Alpha 2 receptors, again, if you block it, because alpha 2 normally relaxes the body, if you block relaxation, you're going to cause excitation, right? Anxiety, tachycardia, and high blood pressure as well. So, beta 1, everything to do with the heart, right? Beta 1 agonists will cause tachycardia, renin release, which will just increase blood pressure in its own way because we retain fluid, which there's the high blood pressure, palpitations, arrhythmia, anxiety. It's everything to do with the heart being excited. Um, for instance, when we take asthma medications like albuterol, one of the common side effects are the palpitations. They could even get to the point, possibly, hopefully never not, but they can cause arrhythmias. They could cause tachycardia because their asthma medications like albuterol are a beta agonist, and they can be non-specific towards beta 2. We want beta 2 because it's that dilation, but beta 1 could also be affected. That's where we get all these symptoms in people who have that use of albuterol. Same thing with the anxiety, right? Beta 1, right? If this all makes the heart go crazy, if we block, like in our beta blockers, this is where it causes the bradycardia. We have less renin release. We have hypotension, fatigue, right? If our blood pressure is low, we're going to be fatigued. And then it could cause exercise intolerance. Same effect. It's going to mess with our ability to, maintain that pressure to function completely. Finally, we have epinephrine. I'm going to just kind of skip a couple things to save you guys on the time because a lot of this is repeated. As mentioned, it is the hormone that actually targets, and this one targets all of them. Targets alpha 1, alpha 2, beta 1, and beta 2. We went over already kind of what each receptor touches on, and it should be a lot of review. And thankfully, it shouldn't be too bad because these meds are pretty straightforward when it comes to it. Again, alpha 2, just remember alpha 2 is the adult in the room that's trying to calm everyone down, but alpha 1, beta 1, and beta 2 are going to be a little too strong when it comes to the signal of epinephrine, and everything's going to be in fight or flight, right? So high blood pressure, vasoconstriction, bronchodilation, a lot of that kind of stuff, and tachycardia and such. Again, this is more just a big repeat of what we talked about in norepinephrine, so I'll spare you guys the jive and I'll just move on to the next thing, right? Same thing. Interesting enough, there is a little new fact in here. If you are agonizing alpha 2 receptors, sometimes there's less insulin secretion, right? I guess in a way, because again, alpha 2 is everything to do with relaxation in the central nervous system. Um, Usually when we're in fight or flight, we get more sugar in our blood, right? Because we need more energy. Sugar helps us make more energy. So I guess, if there's a lot of sugar, it can't get to where it needs to if there's no insulin. So that's kind of where it's coming in. I don't think it's something really crazy to know about. Um, we already went over this, same thing. I guess with the things to watch out, I did add a possible heart block, right? This is why you don't typically just give beta blockers to people with arrhythmias that like could be related to a heart block, because they can make things worse because you're slowing down the electrical conductivity of the heart. I guess that's more just for later by the end of the semester. Um, I did add this one for the beta 2 receptors, right? If they're agonized, bronchodilation, there could be some vasodilation, but it's more the big one is the whole bronchodilation. Vasodilation can occur, it's not saying it isn't. And then more sugar production because, again, your body's put in that sympathetic fight or flight type of response. Obviously, if you block beta 2 receptors, they can cause bronchoconstriction and less sugar production. So, one of the biggest things to teach about with beta blockers, right, like this, if they're non specific, they can make things worse for a person with asthma. So that this is where that's coming in because, again, it, ideally we're trying to block beta 1, but sometimes it could leak out, especially if it's not a specific to that receptor, and it could go to beta 2 and then now contribute to making asthma worse. And that's pretty much it. So again, my biggest takeaway for this, I know I kind of went quick, but if you guys can, because this really helps, it's FYI, you don't need to do it, but it is very helpful to understand these neurotransmitters, look at them a little bit more, maybe look up more videos that probably explain it better than I can, and it will help you understand why is it that certain side effects happen to occur with a lot of these medications. Big last final takeaway, I just, because I can't emphasize it enough, an anticholinergic effect can be seen as a sympathetic nervous system response, i.e., a sympathomimetic response. They're not one to one. They don't mean that they're the exact same thing. However, they present with very similar side effects. Anticholinergics will prevent you from secreting because they stop it strictly because of that. Because we said cholinergic reactions are everything to do with making secretions and digesting and resting. A sympathomimetic, like an adrenaline shot or something like that, will do similar effects, the dry mouth and everything, but not because it's a direct anticholinergic. It's because we're in fight or flight. We need to preserve our body and our fluids and our nutrients, everything we can. So I guess up here we could look at it as, fight or flight style side effects, and then they can branch out with either an anticholinergic or sympathomimetic. They're just not always one to one. So, but again, that's more FYI. Just I want you guys to know that anticholinergics and sympathomimetics have very, very similar side effects. And if you kind of can catch that pattern, it makes a lot of these meds way easier to know. So that's generally it. I wish everybody the best of luck. Hopefully, you guys can catch on to this and understand it, and give it maybe like a couple hours, and trust me, it should really help. So thank you guys.